What I'm going to do is talk for about 20 to 30 minutes on continence and then how we can translate continence into incontinence in stroke. We're going to primarily talk about urinary incontinence, but we'll touch on some fecal incontinence at the end, okay? So how many of our patients do you think roughly are incontinent when they come into hospital, stroke patients initially? It's quite a lot, isn't it? It's about 50 to 60%. It's quite a few. So it's between 50 to 60%. Some of those are going to be incontinent before they come into hospital, but some are going to be incontinent because of their stroke. Unfortunately, it's associated with a very poor outcome. It used to be an admission criteria for some stroke rehab units. If you were incontinent, then they wouldn't allow you in. Fortunately, that's changed now. And continence, you can still rehabilitate somebody who's incontinent. It is associated with poor outcome. You're more likely to die, unfortunately, and you're more likely to be more disabled if you are incontinent on a long-term basis. But most incontinence recovers fairly quickly after stroke, okay? As I said, up to about 20% of those people are going to be incontinent before they come in. As you know, a lot of our patients are of the older age group who are unfortunately incontinent. And there is a slight correlation between sex. So they're more slightly to be incontinent if you're a lady than if you're a man after stroke. And that's got to do with things like pelvic floor and things like that after pregnancy. And as we know, particularly the nurses will know, because of skin integrity, if you are urinary incontinent, you are more likely to get pressure sores. So you have an increased risk of getting pressure sores. It's not necessarily associated with the size of the stroke in the brain, but it's associated with the disability that it gives you, with the amount of disability it gives you. Also associated with aphasia, which is a problem with language, a problem with speech. So if someone can't communicate, they want to go to the toilet. Also cognitive impairments, so things like understanding, belief, perception of things, and obviously someone's functional ability. So if somebody can't literally go to the toilet, then they're going to be incontinent, unfortunately. It will inhibit rehabilitation. Now, rehabilitation is the thing after stroke, isn't it? And if you can imagine somebody who gets to the gym and straight away they need to go to the loo quickly, it's going to inhibit their rehabilitation. Also, the same thing if someone's got a catheter bag, again, if they're carrying a catheter bag, it will inhibit their rehabilitation. And because of the fact that they're at increased risk of disability and it's likely to be a larger stroke, so rehabilitation will be prolonged if someone's incontinent. It can influence where someone's looked after, particularly if there's fecal incontinence. Normally, urinary incontinence we can manage reasonably well, but fecal incontinence will have an influence on where someone's ongoing care is managed, whether it's at home or whether it's in an institution, nursing home. So particularly fecal incontinence will increase the risk of institutionalisation. So is incontinence a disease or a syndrome, or it's not, is it really? It's the consequence of something. That's what incontinence is. And so incontinence is defined not as an illness, but as an involuntary or inappropriate, so it's something that you've got no control over and it's inappropriate, passing of urine or faeces that's going to have an impact on social function or hygiene. Okay? So it's doing something in an inappropriate manner at an inappropriate time, which is going to have an impact on your social well-being. So therefore, being continent is somebody who has the ability to go to the toilet and either have their bowels open or have a wee in an appropriate fashion, in an appropriate place, at an appropriate time. Now, for us in Western society and in Britain, that means going to a toilet and a man standing up normally and using a urinal, a lady using a cubicle and sitting down using a toilet. That's what we find socially acceptable. Obviously, in other parts of the world, the way that people go to the toilet is different. It's still common in many countries of the world to use just a hole in the floor and stand over it, which people find more hygienic. And there are also cultural things with things like in India where they use a hand for hygiene. So there are different ways of going to the toilet. So what we deem as being culturally appropriate in an appropriate time and place and manner isn't necessarily the same worldwide. So if we take that as the definition of continence, are children continent when they're born? No, they're not. They're incontinent. It's something that they learn, and we teach them, and they develop the ability to go to the toilet in an appropriate place and appropriate time. And it's normally between the age of 2 and 3 that they get that appropriateness. What about animals? Are animals continent or incontinent? If you imagine your dog, for those of you who've got pets at home, are they incontinent, or do they go in an appropriate place at an appropriate time? Most of them we train, don't we? My dog's trained to go in an appropriate place. So we train, again, continence in a lot of animals. and even wild animals will develop continence. This looks a little bit confusing, but I'll talk through. It's actually quite simple. It's a really interesting reflex in the body, in the brain, and it controls whether we go to the toilet, and when we go to the toilet or not. It's very similar in micturition as it is in having your bowels open, but this is specific to micturition. And what happens, the bladder is made up of muscle, of detrusor muscle, which is a fibrous muscle. It sits across each other like that, so it has the ability to expand and contract. Okay, and so as we drink more, the bladder takes more and more fluids and expands and expands. Roughly about how much will the bladder hold before you get the urge to go to the toilet? It's about 250 to 300 mils in a normal adult. Okay, it'd be less obviously in a child, but the bladder will take about 250 to 300 mils, so a good glassful, and then you start getting the urge to want to go to the toilet. And what happens, there's some afferent fibres that send messages along that green path to the sacral reflex, and the sacral reflex is at the bottom of the spine here. So this is the spine, and there's the brain, and there's the bladder. So the sacral reflex will get this message along these afferent fibres saying this bladder is getting fuller and fuller and fuller, and this person's going to need to go to the toilet soon. So then the pathway goes up to the micturition centre, which is in the frontal lobe in the brain, and that micturition centre inhibits the sacral reflex to stop it from working. So it sends a message down saying, hang on, wait a minute, you're standing up in front of a group of people talking to them, this isn't the right place to go to the toilet. So I might have 300 mils in my bladder and feel as though I want to go, but my sacral reflex will inhibit, or the frontal micturition centre will inhibit the sacral reflex from making me go to the toilet. As soon as I've finished with you, then I know then that I can leave the room and go to the toilet. The sacral reflex will then say, okay, now's a good time to go to the toilet. It'll make me feel as though I want to go to the toilet. I can go out, find an appropriate place, an appropriate time, and go to the toilet in an appropriate way. So when I found that place, the message will be sent from the sacral reflex to the bladder, the detrusor muscles will contract, the bladder opening will open, and I'll be able to go to the toilet. Prime example is if you're going on a long journey and you've got 3 kids in the car, you all ask them all to go to the toilet before they leave home, and they go, and after about 150 miles or so, one of the kids will say, Dad, I need to go to the toilet. Nobody else does, but one of them does. And so you pull over into a motorway service station, stop the car, and then everybody gets out to go to the toilet because they know that it's an appropriate place. The sacral reflex, or the frontal micturition centre, has said, right, you're in an appropriate place to go to the toilet here. Take your chance while you can, and it'll send a message to the sacral reflex saying, make them feel as though they want to go to the toilet so they can. Okay, so it's a very clever reflex, okay? So what are the causes of incontinence in stroke? There's 2 main causes. There's the problems associated with the detrusor muscles, and then there's the other causes. And the 2 main causes for the detrusor muscles are hyporeflexion, and hypo is less, isn't it? So there's less of a flexion within the detrusor muscles around the bladder. And if you get less flexion and something gets bigger and bigger and bigger and bigger, what you're going to get? You're going to get somebody going into retention. So they retain the urine in the bladder. So they're less reflexing, so they're less flexing. They'll open up, and they'll just continue opening until you relieve that bladder. So you get a retention. And the other one is hyperreflexion, so they become hyperreflexive, and that means that they won't take as much urine, and as soon as you get to a particular point, they'll contract, and you get an urge incontinence. So you can only take maybe 50 or 60 mils of urine into the bladder. If somebody feels that they really need to go to the toilet, they have to go there and then and pass urine. So one is the typical retention of urine, and one is the typical urge incontinence of urine. So they're the 2 main problems associated with damage to the brain because of stroke. The other ones are all down to things that are associated with stroke. So things like a reduced level of consciousness. So if somebody is unconscious or has a reduced level of consciousness, they can't go to the toilet. Somebody who has communication problems and can't speak. Somebody who has an impaired arm function, particularly a gentleman wanting to use a bottle, for instance. Ataxia is poor coordination. So again, somebody using the bottle, but if they've got poor coordination, they won't be able to use it. An infection can cause somebody to pass more frequently, which might have a problem with continence. Fecal impaction, excess urinary flow. What could cause excess urinary flow? Things like someone who's on diuretics or drinking an awful lot, or someone with a poorly controlled blood sugar can cause excess urinary flow. Unfortunately, we don't see it quite as much anymore, but too few carers and nurses. I mean, hopefully now if I went onto any of the wards here, I wouldn't see what we used to see years ago. You know, Mrs. Jones sat in the bed saying, nurse, can I go to the toilet? And the nurse saying, hang on a minute, I'm just giving so-and-so a cup of coffee or whatever. You know, priorities wrong. Hopefully we don't see that sort of thing anymore. And things like cognitive problems, so understanding problems, behavioural type problems. The most important thing when we look at assessing continence is to discuss it, A, with the team, but also really important to discuss it with the patient. Some patients, particularly elderly patients who have had quite a large stroke, may just assume it's an inevitability of having a stroke. Well, it isn't. Most continence we can treat really well, and most continence we can remedy. Okay, so it's really important to discuss it with the patient and be open with the patient and with the carer, but also with the team, because very often it's part of the multidisciplinary team who will detect continence. So it's important in your multidisciplinary meetings, whether they're weekly or daily, to discuss continence with each patient. And also to continue to discuss it in the long term. So if you're seeing somebody like I do 6 weeks, 6 months or annually afterwards, it's still important to discuss continence at that point. Because as I said, most continence is remediable. We can manage it very well or cure it, okay? It's really important to distinguish between an accidental and a true incontinence. So a gentleman who wakes in the middle of the night, who tries to use a bottle but fumbles a bit and accidentally spills it in the bed, that's not a true incontinence, that's just an accidental incontinence. It's also really important to monitor urine volumes, so how often someone's going to the toilet and how much they're passing. It's useful to use a urine chart or a frequency chart to do this, so we can determine whether someone's got an urge incontinence. If they're going 12, 15, 20 times a day and only passing very small amounts, then we know pretty sure that they've got an urge incontinence. It's also important to dipstick a urine, perform a urinalysis, looking for things like sugar, for signs of diabetes, blood for signs of infection, and things like nitrates and protein for signs of infection, again, which can have an impact on continence. And if we do detect any signs of infection, then we send a sample off for culture and sensitivity to see if any bugs grow in it. And also, it's really important from a retention point of view to check a post-micturition bladder volume. So after someone's gone to the toilet, just check how much urine there is still left in the bladder. We can do this in one of two ways. Bladder scanners. Are you all familiar with bladder scanners? Yeah. Very simple procedure. You just ask the person to go to the toilet, and using a very simple scanner, you scan over the bladder, and it'll give you a post-micturition or a post going to the toilet bladder volume. Persistent volumes over about 100 mils would indicate a retention. And if you're retaining continually 100 mils or more, then you're putting yourself at increased risk of infection. Or you can introduce an intermittent catheter, which is a catheter which is introduced into the bladder, urine's drained out, and then it's taken out, and it can be reused, but in hospital we throw them away. And so it prevents having an indwelling catheter in all the time. Okay?